wow, our cycles impact all of these pieces so much more than I think anyone has ever been told, and especially more than any woman ever gets let on, right?
Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi, and welcome to this week's episode of the Dutch Podcast. Today, we're going to talk about something that affects so many women, and that's mood changes, irritability, and emotional volatility tied to our menstrual cycle. We're going to talk about PMS and PMDD, but also just generally what we ended up calling the premenopausal ick, which is what a lot of women experience, even if it doesn't progress to that point of PMS. Now, what I want to talk about with you guys and what we're going to talk about on the pod is the fact that this is a multifactorial condition or a symptom. It's not just driven by hormonal imbalance. In fact, a lot of times hormones are perfectly balanced, and the problem is the way your body is responding to the normal changes in your menstrual cycle. So our guest today is Dr. Saru Bala. She's a licensed naturopathic doctor and a women's health specialist who's dedicated her practice to helping women understand and reclaim hormonal health. She has a very unique perspective with training as a naturopathic doctor and also training in neurobiology from the University of Texas at Austin. So Dr. Bala brings this multimodal perspective where she looks at hormones but also is an expert in neurotransmitters. She also layers in a lot of her personal experience into her work. She had years of navigating her own unresolved gut, period, and hormonal issues, and she's really built a practice focused on getting to the root cause of what conventional medicine often misses and dismisses. She does one-on-one work, and also she's run the Period Solutions Academy, and over the course of time, she's helped thousands of women connect their cycle symptoms to their underlying hormone patterns and finally get answers. Let's go ahead and find some answers today. Let's get started. So, you came to this work through your own health journey. Can you share a little bit with our audience about what you were experiencing and what you felt like was really missing that drove you to become an ND?
Yeah, I dealt with period issues probably, as long as I had a period, and I just never knew that you could do anything about it, right? I feel like in society you're kind of told, oh, well, your mom had these issues, and if you have a period, this is normal. So I obviously going through naturopathic medical school, I was like, oh, maybe it's my liver, maybe it's my gut. And I realized, and kind of addressing those pieces myself and seeing my symptoms improve, I realized, wow, there's a huge gap in how women are served and what they're told and what they're being given by their OBs and their conventional providers. And so it was really nice for me to see that, oh, look at how much my life has changed. Let me help other women feel the same way, because there's a lot of just simple things out there that we can do for our gut and or for our periods and see a huge difference in just the quality of our life. So I was very excited to scream that from the rooftops once I figured that out for myself.
I love that you shared that story because I had a really similar experience. And I think it's like in the conventional healthcare space, when it comes to women's health, things are starting to expand now, but only because they're embracing integrative modalities. But at the time, and even now, it's like OCP, or oral contraceptive pill, like put them on the pill, put them on the pill. And while that can help with symptom pictures for women, and it's not, if women want to be on birth control, there's nothing wrong with that. But it doesn't fix the root of the problem. And I think I share that with you where it's like I want to scream it from the rooftops. And it's such an inspiring area of medicine because there's just so much we can do when you look outside of the pill box.
Yeah, absolutely. I agree.
So it's super interesting because your background before naturopathic medicine was in neurobiology. So how does that shape the way that you look at the connection between mood and hormones? Because you have this background that really looks at it from multiple angles.
Yeah, I think, we see it all being very connected, as you know, too. The brain, the gut, the hormones, our cycles, everything is very connected. And I think the more I got into women's health, the more I realized, wow, our cycles impact all of these pieces so much more than I think anyone has ever been told, and especially more than any woman ever gets let on, right? If we're, feeling a little irritable and moody before our periods, it's just, oh, you're a woman, oh, it's that time of the month or whatever, dismissal we get. without recognizing there are neurochemical changes that are happening because of our hormones and because of our cycle. And so the more you can just understand that in your body a little bit more, I think the more that we can feel a little bit more in tune with, oh, these changes are happening. I'm in my luteal phase. What can I do to support myself versus feeling like this is just how I am. There's nothing I can do.
That's such an important point. I mean, I think that a lot of times people, they frame up hormone related mood changes as just like a personality defect, right? Yes. It's just like kind of who you are or who you are as a woman, or but it's really well documented in research that cycle related shifts in hormones create, and stress as well. You can be more susceptible to stress. You can have anxiety, depression, irritability. There's just so much that's been documented, but still women get very dismissed in my experience because they come to us after, right? They get dismissed over and over again, and really not given a framework for finding help or like addressing what they're really experiencing. Why do you think it is that women are just, these symptoms end up getting dismissed as something that's normal rather than something that needs to be really worked up versus being just part of being a woman?
Right. And I think that just comes down to just the way the healthcare model has been set up until, now that we have social media and just all the abundance of information people have. Prior to this, you would go to your doctor and you were kind of at the mercy of whatever they thought was going on or whatever they could give you. And in the conventional model, we do see that things are much more black and white. Things are much more, well, do you have a pathology? There's nothing wrong. I can't diagnose you with anything. There's really nothing I can give you here. And we're seeing much more that there are so many dietary lifestyle changes that you can make that will impact upstream what's happening with your hormones, what's going on, so that downstream, the next cycle, 2 cycles, 3 cycles from now, you do feel better. So I think, I don't want to necessarily say it's the system, but it might have just been the system and how we're kind of, how things were done before. And so without the education side of things, people were just like, well, I guess I have to, be on an OCP, or I guess I have to be on birth control. I have to do something to stop these symptoms, instead of working with their body and seeing, well, what is it that I could change that is affecting my cycles or symptoms?
It's really interesting that you bring that up, just the system model, because you're absolutely right. Like, our healthcare system is based on treatment of disease, but not on treatment of dysfunction. And like, dysfunction leaves people really uncomfortable. I think about gut health as a big thing. Now I think that we're doing a lot better on IBS, but like 10 to 20 years ago, people would just be told like, oh, you've got IBS. Good luck,
Good luck, right?
See you later. Yeah. Like, you don't have colitis, so,
Right. So be happy.
You're discharged from the GI clinic. Now I think that, I remember one patient said, the only part of the IBS diagnosis, I believe, is the BS part. And it's still one of the best things that I remember from a patient visit ever. But I think it frames up the fact that hormones are really similar. There's obviously this world of dysfunction that's not diagnosable as a disease. And I think that just leaves women kind of stuck in limbo a lot of the time.
Yeah, absolutely.
Well, I want to talk about the mood disorders that are diagnosable, PMS and PMDD, because these are these kind of well-recognized cycle-related mood disorders. Could you just start by explaining what they are and what the difference is between the two?
Yeah, so PMS is that change in your cycles right around luteal phase, right after ovulation, that you're noticing in terms of, I feel a little bit irritable, I'm not myself fully, I feel a little low. You might just notice these mood changes, but they're not getting in the way of your day. You're still able to go to work, you're still able to have functional relationships, you're still able to get out of bed and feel like a person. You're just not maybe 100%. Whereas PMDD is going to be more of, it is affecting your day. It's affecting how you relate to your coworkers. It's affecting your work life. It's affecting your relationships. And it's really kind of impacting your daily routine. So when it gets to that level, that's when we can typically call it PMDD versus this is PMS, a syndrome, versus an actual diagnosable PMDD disorder.
So they really are a very similar symptom picture. It's just the severity that ends up pushing them to one. Now, explain to me a little bit about your experience with women coming in who maybe have a prior diagnosis of depression or anxiety. Have you had instances too where that's almost like a misdiagnosis, or it really should have been categorized as more of a hormonal disorder, but maybe they've never looked at hormones?
Totally. I have a lot of women that I work with who have specifically like PMDD-like symptoms, or they come to me thinking, I definitely have PMDD. And the reason that we know is because the second your period starts, or maybe a day or two after, you completely feel normal again. You don't have any symptoms where you're like, I'm totally fine. I feel great. I feel like my normal self. And then you ovulate and the switch kind of flips. So that's really where we see those PMDD symptoms kind of amplified and reflected as more than just anxiety or mood disorder. It's really like, okay, this is very cyclic. Like the second you ovulate, you're seeing this huge shift. And then it goes back to normal. That back to normal is really important because a lot of women, they do just have anxiety and then they have PMS on top of that. So it feels amplified, but their baseline is still anxious. That's going to be different than PMDD, where you completely flip and then feel back to baseline normal again after your period.
That feels like a really important distinguisher because it's not always one or the other. You can have both, but I totally get what you're saying, that you're going to see amplification of it at certain times in your cycle where things will be worse, harder to handle. I mean, I don't know a single woman who hasn't like had that time at the end of the month where they're like, oh, I just need to like leave my husband and my kids and go somewhere. Like I need a new life. And then like 2 days later, they're like, oh no, I feel better, but I did get my period.
Right, exactly. It's like, why did I say that really mean thing 3 days ago? Oh, just kidding. And then you look in your underwear and there your period is. Yeah. So
exactly. And I think so this is a really important distinguishing factor because I don't say that to downplay the impact of hormonal mood disorders, but I do think there's an element of experience that many women feel that don't move up into that criteria of a diagnosis, or it'd be like a mild or occasional PMS. But this can become really serious for women. It needs to be something that's taken really seriously.
Yes, absolutely.
So can you talk us through what is actually happening hormonally that ends up kind of affecting that window where symptoms tend to peak with PMS and PMDD?
Yeah, there's definitely several things going on around that time. I think for most people, they can agree that they have that one, maybe 2 good weeks after their period starts. They feel really great, and then they can feel themselves kind of shifting into that phase of that luteal phase. And what's happening is, estrogen and progesterone are neuroactive hormones. They directly can modulate our neurotransmitter systems. And estrogen is going to support serotonin receptor activity. And so when it drops, that serotonin activity kind of drops with it as well. And progesterone as well converts to what we have a compound called allopregnanolone, which is a direct modulator of our GABA receptors. And GABA is really responsible for kind of helping us feel that calm sense of grounded safety. And so when we have these shifts in our hormones, or if you have hormonal issues where progesterone's on the lower side, you're going to see more of that excitatory activity. You're going to feel more of that anxiety if you don't have enough progesterone there. If your estrogen levels aren't adequate, or if you see a big spike and dip between estrogen, you feel really good and then it comes crashing down. And if your liver and gut maybe are having some trouble processing those things, you're also going to see just a bigger drop and a bigger kind of flip in those symptoms that you're experiencing. And then, of course, the just general anxiety and stress of our day also plays a role, right? Because as things shift in our luteal phase, that shifts our immune function, that shifts our cortisol response as well. And so if we are already kind of in that nervous system state of fight or flight constantly, and then we hit our luteal phase and we're just even deeper in that with low progesterone now and gut and liver issues, we're just going to see that amplified even further. So that's kind of the big loop we get stuck in of, well, I'm already stressed and then I hit my luteal phase and I'm even more stressed. I'm not able to keep up with these things that I need to do to make myself feel better. And then you're not doing those things. And it just becomes this awful cycle of I feel like crap and I'm continuing to feel like crap because that's making those hormonal symptoms worse too.
I love the way that you're explaining this because I think there's so many places I want to go. So I have to like slow myself down because there's so many follow-ups for you on this. I think generally, I just love the way that you just explained that, which is that when you have stress and like too much stress and dysfunctional stress, we would call it like HPA axis dysfunction, right? That I think about that as being what manages your resilience or your ability to manage change and stress, right? And that system can become overloaded. And what I'm hearing you say is that the hormonal fluctuations are like a trigger. It's like pushing a button, right? And if your stress cup is already overflowing, that's one more change for your body to have to deal with, and that predisposition of low resilience because you're in fight or flight and you're not sleeping or whatever. All of that makes these other things worse.
Right. it's kind of compounded. Your luteal phase, I like to say, it's kind of the mirror for how you've just been functioning at baseline, and things can either be mirrored in a good way, or they can really show you kind of where all the deficits are in the maybe lifestyle habits, nutritional habits, whatever it might be, that aren't happening at the other times of your cycle.
So I also love that you broke down like what the connection between estrogen and serotonin, and then the connection between progesterone and GABA, because both of these hormones are really important. And I see so many, even just wellness influencers talking about PMS as a progesterone deficiency. Can we like bust that myth real quick about like, is the issue here low progesterone?
Not always, especially with PMDD. You might notice, and oh God, this is where I could get into a whole soapbox about this, about how.
Let's get in the soapbox. That's why we're here. We are a soapbox-friendly environment.
The biggest thing that I see so many, whether that's influencers or coaches or even functional medicine providers, I see that too. They think, oh, well, you have PMS, here's progesterone. And for so many women who are maybe teetering on PMDD or full blown into PMDD, progesterone is not always the answer, because again, there's so many of these nervous system inputs that are going into your everyday life that are also affecting how your output of stress and mood and all of that is. And so giving you progesterone isn't necessarily changing that input signal, right? And so I think a lot of women can agree. They're like, yeah, I tried progesterone. It did nothing for my mood. Like, yeah, sure, maybe my periods got a little lighter. Maybe my clots got a little bit better. Possibly even my, like pain symptoms, because yes, it is kind of acting locally there. But those bigger mood symptoms, those bigger changes, most people don't see a huge shift there.
Well, one thing that I want to make crystal clear for listeners is that the research is really clear that PMS and PMDD in most cases are not due to hormone imbalance. In fact, when you look at women with PMS and women without PMS, the cycle dysfunction from a hormone standpoint exists at about the same rate. So it's not like if you have disrupted hormonal cycles, like your estrogen and progesterone are off, that you're more predisposed to PMS. What it seems to be is that the PMS and PMDD are an irregular response to normal fluctuations in hormones.
There you go.
So
yes,
you can have an absolutely perfect menstrual cycle and still have PMS and PMDD, because it's all about what those hormones do or how your body responds to withdrawal, like you talked about. So can you just let's just dig into that a little more, because I really love that you have this neuroscience background to really help people explain that and explain why. I mean, I guess you could argue that providing stabilization of the hormones at the time where they're normally drop, which is what an oral contraceptive does. It's like a steady state dose without fluctuation. That's why women often feel better. So you could give a little bit to kind of bridge the gap, but ultimately the fluctuation is not the issue.
It's really not. And that's also why with PMDD, even sometimes with PMS and just like that half the month anxiety or mood disorder changes that women experience, they often get on Zoloft and they're like, I feel so much better. And that's a huge indicator that it was never your hormones in the first place, right? It's like, if we're doing this thing that every day of your cycle you're taking and just that half of your cycle is affected, it really kind of shows that, hey, it's likely your nervous system and how things are kind of happening throughout your cycle, that when those hormones are shifting and changing and rising and dropping, that's really a big factor there.
We'll be right back with more. At Dutch, we empower providers to confidently integrate functional hormone testing into their practice. Registered Dutch providers gain exclusive access to hormone education courses, including our Mastering Functional Hormone Testing course. This course shows providers how to effectively use Dutch testing to assess and interpret hormone levels in both male and female patients. You'll learn more about hormone testing basics, including estrogen, progesterone, and androgen levels, as well as adrenal function and HPA axis health. Register for this course on the homepage of your Dutch provider portal, or become a Dutch provider today to get access. Welcome back to the Dutch podcast.
So let's talk a little bit about Dutch testing, because I think that's one of the reasons why I love the Dutch test, is you talked about the connection between stress and stress management and estrogen and progesterone and kind of all these cycle-related impacts. Can you talk a little bit about like the standard hormone testing workup that women might receive, and then what you do differently from a functional medicine perspective, or how the Dutch test like creates more insight into what's going on for women?
Yeah. So the standard blood work that women might receive, if they get any at
Yeah,
all,
it's like this
uh,
goose egg.
yeah, right. I have so many patients who come to me and they're just like, my doctor told me that there's no point in testing your hormones. This is the most annoying thing I hear. There's no point in testing your hormones because they're fluctuating. And I can't tell you how many times I hear that, which is so, we know what your hormones should be doing. We know we even have ranges on the standard lab panel itself for what your hormones could be doing throughout your follicular, ovulatory, and your luteal phase. So we know kind of where the functional ranges too can lie within that. So I really like to make sure, at the very least, we are testing your hormones when you're experiencing the symptoms the most as well. So we know that a week after ovulation is really when we're going to see peak levels of your progesterone. How much is your corpus luteum? How much are you able to produce? How strong and robust was your ovulation? Because that can really give us some insight into, is this even a low progesterone issue to begin with, in terms of maybe some of the other symptoms you're experiencing? Or is this really just a nervous system input? So looking at estrogen, looking at your progesterone levels in your luteal phase can be helpful. Looking at your DHEA, I really love looking at DHEA as well, because that can kind of give us a little bit of insight into what's going on with your just stress and your resilience. How, if we see it typically on the lower side of the range, we can kind of assume that you've been in a chronic fight or flight state for a really long time and you're kind of in that burnout phase, as we call it. Or if it's more on the higher end of the spectrum, I typically like to think that that's more that you're really in this acute state and things are really heightened right now. So we do like to see a very mid-range for DHEA. So that's another thing that I think a lot of providers are not looking at. And then insulin, hemoglobin A1C, and glucose together can be a really, really great one at looking at blood sugar, because your blood sugar is also affecting cortisol and nervous system and your moods as well. And especially in the luteal phase, when our progesterone does come up a bit, progesterone makes you a little bit less sensitive to insulin. So that can also be a factor of, you're craving a lot of sugar, you're craving a lot of carbs. That can affect your moods as well as changing your overall, how your gut is also metabolizing things, and that's going to change your serotonin as well. And so there's so many different inputs that kind of go together all at once that we really want to make sure we're looking at the whole picture and not just, well, what's your estrogen and progesterone doing? Those look fine, so you're good to go. Because again, insulin, blood sugar, DHEA, all of these pieces matter as well.
At what point in time do you feel like I need to look at cortisol as well? Like I need to look beyond the cycle hormones and really take a look at the HPA axis?
Yes. Okay, so I do love testing cortisol as well. I love doing the Dutch testing for the cortisol with the 4-point, because as we all should know at this point, cortisol fluctuates throughout the day. And so if you're just getting that morning cortisol or just that one piece of serum blood testing cortisol, it's really not giving you the full picture of what your cortisol is actually doing throughout the day. In the morning, we want it to rise. We want it to be really high. And then as we get to the afternoon and evening, it starts dropping, and that's totally normal, and that's what we want to see. So seeing that full 24-hour curve is really important, which is why I love measuring it through the urine metabolites. And so if you are struggling with things and symptoms like having trouble falling asleep at night, if you are really struggling with feeling really wired, having racing thoughts, if you're struggling with waking up in the middle of the night, or waking up in the morning feeling really groggy, tired, hitting snooze 1,000 times, waiting for that coffee to hit before you have any energy, all of those are really warranting, let's look at what your cortisol pattern is doing, because I bet we'll find something a little bit off there.
I love that you think about that and think about that way. I also love the cortisol awakening response as a measure of kind of your resilience or ability to mount a response to a stressor. So I would add that too. And just from a Dutch perspective, we kind of have two main tests, the Dutch Complete and the Dutch Plus. The Dutch Plus is salivary cortisol. The Dutch Complete is urinary cortisol. So the Dutch Complete is a little easier to measure, but with the saliva, you can get the cortisol awakening response, which I oftentimes see dysfunctional even before we see changes in the diurnal, like day-to-day 4-point pattern. So just want to put that out there for providers. Like I think in particular, these patients are really good candidates for that extra salivary measurement.
Yes. Awesome. Good to know.
I also am wondering if you ever do cycle mapping. Have you ever done that with this group of patients where they're getting, because you'd mentioned I really like to measure at the time that they're having symptoms. And of course, with PMS and PMDD, you're talking about the later phase of the luteal phase, but sometimes these people you'd mentioned ovulation at one point, they might get ovulatory symptoms or something that you'd say, okay, we've got to do a little bit more testing that covers that part of the cycle. Can you talk a bit about that?
Yeah, absolutely. I know there are a lot of different ways of measuring that these days, and I know Dutch has kind of been the first one to offer that whole cycle mapping throughout your whole cycle, which is great. So yeah, I do love being able to see throughout your whole cycle what is happening. And I do often find that a lot of women think they're like, I think I have estrogen dominance, and it turns out their estrogen is actually much lower than they thought it would be. And so when we see that throughout the cycle mapping, you can kind of see, okay, maybe it's, and like we know with estrogen and serotonin and how those two are very closely related and how we see those shifts, it's really important to see that I think progesterone gets all the blame for so many things when often it can be estrogen that's also showing up, especially in the follicular phase. If we're not getting that supportive response, that can also be a factor, especially around ovulation for some of those mood disorders as well.
Yeah, that's really interesting that you bring that up because I think, estrogen is so powerful. We talk about progesterone like it's this princess hormone, and I feel like estrogen gets spoken about more as a negative, estrogen dominance and all the symptoms you get from too much estrogen. But really, estrogen is so critically important for our health, and we should be thinking of it as the queen, not
I agree.
the problematic joker or whatever.
I
And
know.
and I see this sometimes too. I personally just started to do half of an estradiol patch, menopausal patch, for kind of the bridge week for the last week of my cycle because I was getting menstrual migraines, which that's a totally different topic. That's starts on day one. But just that tiny bit of low dose estrogen when it's dropping out has prevented me from getting migraines. So I only wear it from, let's say cycle day 26 to cycle day 2 or 3, and I'm fine. But it makes me think about, the other side effect of that that's beneficial is I feel like it's eliminated that premenstrual. I wouldn't have said it was PMS, but just kind of ick, the premenstrual ick, I'll call it, that I was experiencing. I don't know what else to call it, but
I like
a little bit.
Yeah, the PMS ick.
The PMS ick. We're just coding this is going to be a new thing, which is kind of I would say kind of normal experience that's not severe, that's not interfering in your life, but you can definitely feel that your period's coming on or you're feeling more irritable a little bit, things like that. So it just speaks to the fact that don't always think about progesterone. I love that you're think about estrogen as well.
Yeah, no, and estrogen has so many other benefits for different areas of our heart health, our skin, our bones, our everything. And yet we're just well, estrogen's bad. And, I think people, yes, we need to treat it
it's not bad. Let's give it some love.
Bad. We need it. Yeah. That's why we feel good in our follicular phase. It's thanks to her.
Exactly. The other thing on Dutch that I want to just call out for our listeners is I know you talked before, Dr. Bala, about the fact that you're looking at one of the benefits of progesterone is it crosses the blood-brain barrier and you get this metabolite allopregnanolone that helps bind GABA and is relaxing. We actually can measure women's capability to make those alpha metabolites that are beneficial in the brain. So on the Dutch test, for those of you listening, we don't measure progesterone on its own. We measure 2 progesterone metabolites. We measure alpha and beta pregnadiol, which alpha pregnadiol is made similarly to allopregnanolone. Those are both alpha metabolites. So you can also take a look at the Dutch test with those metabolites to see which women would be better able to make those alpha metabolites. And I've also just seen times where I see this mostly postmenopausally, but women are or perimenopausally, I'm not sleeping, I want to take progesterone, and it really helps some women, and for other women, they just don't seem to feel a benefit. And when we look at Dutch testing, you can see they make more beta metabolites, and they either need a higher dose or they need just a totally different therapy for that support. I just want to call that out because I'm sure you're looking at that on the Dutch test too.
Yes.
Because it makes a big difference with people feeling calm and relaxed or could impact feeling more anxious.
Yep. And with PMDD too, we see that a little bit skewed with the Dutch is I see a little bit more of that beta versus alpha for the progesterone metabolites there. So that's a good point.
That's super interesting. So I know that we've talked about stress vulnerability in the luteal phase and how it's linked to these hormonal fluctuations, and we've talked about the role that estrogen and progesterone play, but the real work comes from building a protocol that kind of addresses the root causes for each individual woman and in a way that's sustainable long term. So once you've collected all this hormonal data, what does it look like for you crafting a root cause based protocol for a woman that has these cycle related mood symptoms?
Yeah, that's a great question, especially because a lot of times it's already impacting their ability to just go about their daily life. So it
Yeah.
really, I like to see what are you able to do? What kind of changes can we work in? And so in the beginning, it is definitely going to be the slower, smaller, tiny things to start creating a little bit more of that space in the bucket, a little bit more of that nervous system capacity so that we can add more stuff later. So it really starts with a good bedtime routine, right? As we talked about with the cortisol, that's a really, really big factor for so many people. There's a lot of cortisol dysregulation going on. Your cortisol isn't rising in the morning. You're not getting that cortisol awakening response, or maybe your cortisol is really high in the evening when it should be low, starting to secrete that melatonin. And we're not seeing that. And so that's where I want to start is how can we get that cortisol rhythm, that circadian rhythm back on track? So really small things like sitting outside for 10 minutes at dusk and dawn or just in the morning, getting that cortisol awakening response to getting that sunlight in your eyes to kind of set that melatonin cortisol rhythm, or breathing right before you go to bed. If you can add 10 minutes of breathing, because not only do we have research to show that breathing for 10 minutes twice a day can help with anxiety, it can also help with your cortisol levels over time to get them a little bit lower. And when we're in the nighttime, when we know cortisol should be its lowest, melatonin needs to rise. So kind of getting those two back on track in all the different sleep hygiene ways that we know. So I really like to influence light with sun to support cortisol and melatonin. Talking about breathing as much as you can, just little things that you can do no matter how busy you are. You know, you eat dinner outside or have your coffee outside while you're doing whatever else you're doing. Adding in 10 minutes of breathing that you can kind of do anywhere you are. So little pieces that don't necessarily require you to buy a bunch of stuff or have to change your whole, routine around is really helpful, I feel. And actually today I talked to someone who she had a patient who had really intrusive thoughts in her luteal phase. She's like, I noticed that as soon as I ovulate, these thoughts just come out of nowhere. But she's been sleeping so much better since we started doing a lot of these circadian rhythm pieces. And she's like, my anxiety and my heart palpitations have gone away. It's just the intrusive thoughts that I still have. And it's only been like 1.5 cycles of adding that in for her. So I think a lot of people dismiss these really easy, simple things that they can add into their routine and don't, because it makes a really big difference.
Well, I think you're right. It's interesting because I always tell my patients, like, this is very simple, but it might not be easy, because
Yes,
simple and
yes,
easy are not
thank
always
you.
the same.
Yeah.
They're like, can you just give me a pill for that? Like, do I really have to breathe?
Yes, exactly. Yes.
Do I really have to go to bed early? Like, don't you just have a supplement you can give me instead? But I love that suggestion. And particularly with like the reducing fight or flight. There was a really cool study that I'll try to find and put in the show notes here, but it was on the physiological sigh as a really good cortisol lowering technique, which I'll just talk about. I don't know if you use that with your patients at all. I used to recommend more box breathing because it was so easy to explain. But physiological sigh had this cool study. So physiological sigh is when you take a deep breath in, and then you when you get to the top of it, you pause and you take a second sip in. And then when you breathe out through your mouth with a sigh. So it's like this. I'm gonna try to do it into my microphone.
Yep.
Hopefully our producer's not like, what the heck are you doing? So you take a deep breath in. That's essentially one round. And you do that 10 times, which, I mean, how long does that take me? 3 to 5 seconds. And it's actually, when you take that second deep breath in, it expands your lungs and presses the diaphragm, and it compresses on the vagus nerve, which is one of our parasympathetic nerves. And so it actually has a mechanical impact on the vagus nerve that can help to slow down. And so that's just another one that I like to share because
That's huge.
anybody can do that, and it's free. And I think about all, I think in functional medicine we get criticized for putting people on these $1,000 protocols, but sometimes the patients want the $1,000 protocol because they don't want to do the free stuff that's simple but not easy.
Yes. I know. And that's my biggest thing is it's simple but not easy, but it can be really effective because you don't want to have to be on a supplement for the rest of your life. So
Right, exactly. You've got to get this stuff in there. But I love your point about kind of starting where people are at, because particularly if someone's experiencing depression, if you send them home with a 20-point protocol,
it's really hard.
and they feel overwhelmed and they can't put it into their life, nobody wins, right?
Nobody
So I
wins.
think even if it feels too small to matter, picking something that's either easy to do or something that the patient identifies, well, I could make a change to my nutrition, or I could go to bed earlier, or I could take a walk every day.
Yes.
whatever that thing is, like let them get some wins under their belt
Mhm.
before you start to layer things on. Is that the approach that you take there too?
Absolutely, yes. I always like to say, if we can't set up a healthy foundation, the house is just going to crumble. So we can add in all the supplements that you want, but we really want to set up a good foundation, because a lot of what I see too is they'll take the supplements and they're like, I feel really great. And it lasts for a couple of cycles. And then they're right back to where they started, because we're adding the cherry with no cake. There's no foundation, right? And so you really want to make sure that you're setting up your nervous system so that when you take and add those supplements in, you're going to have a much bigger impact than just adding the supplements, seeing a short-term benefit, and then long-term you're still back where you were.
Yeah, I love that. So are there any other like supplement protocols that you really love to think about? Like you always start with the adrenal function, or what are the other, and I know for PMS and PMDD, there's some great research on a couple of specific nutritionals. You want to share some of those?
Yeah, absolutely. I'm curious to know what the ones that you're thinking of are, but
Okay.
I honestly recently have been loving L-theanine. It's an amino
Mm.
acid found. It's an extract from green tea, and is really simple. It's very safe, very effective. You can use it whether you're pregnant or breastfeeding, which a lot of the women I work with are also doing that. So it's hard to introduce extra supplements and other things, and L-theanine is one that is very safe, effective, and I have patients who have like panic disorders or just get panic attacks a lot, and all I have them do is add L-theanine, and just that takes them from daily panic attacks to being able to go about their day. So I just love how effective it can be at a higher dose. I think a lot of us think, oh, I can drink green tea and get enough. You're going to want likely more, closer to 200 to 400 milligrams. And because it has such a short half-life, you can actually use it throughout the day as often as you need it. So I typically tell people, take it when you need it, as often as you need it. It's not going to make you groggy. It's not going to make you tired. And it can be really helpful for just lowering that stress. I kind of tell people it just turns down the dial. It's not going to be like taking a Xanax, but it is like going from an 8 out of 10 to maybe like a 4 or 5 out of 10. And just that really helps a lot for some of those PMDD symptoms, some of those the stress and anxiety that can kind of peak around luteal phase as well. So my recent go-to is L-theanine, like I said, because it is such a simple thing to add in. It's not a blend of 1,000 different things. You don't have to know, okay, are you allergic to this, or do you react this way to something like valerian root? I know some people really react negatively to that. So that's one. And then just for general resilience, if you're in a phase of life where you're in a grind, maybe you're postpartum, maybe you had your third kid and you're just really, it's a lot, supporting yourself with some adaptogens is always a great idea, just to give you that baseline extra support for your adrenals. So there are several different blends that you can use and different types, but any kind of adaptogen blend that has a good amount of those specific herbs that you are using is always.
Do you have
great.
any favorite herbs?
My favorite herb blend is actually the HPA Adapt from Integrative Therapeutics.
That's a great one.
Yeah, it's really gentle. It's not super harsh. I also really love the Adrenal by RLC Labs, but that one has glandulars in it. That one is a little bit more intense, but HPA Adapt is just more calming, more gentle, and kind of just an overall support. So the Eleuthero, ashwagandha, rhodiola, I think there's maca in there, and then there's one more thing that I can't remember is in there, but I generally like that blend as just a go-to overall.
That's awesome. Yeah, I think the ones I would throw in, I think there's some good baseline nutrients that actually have great randomized control trials for PMS. Believe it or not, calcium has the strongest data, which is probably not what people would think about regularly, but it seems to modulate the effects of dopamine and serotonin. So that's kind of a funny one that you wouldn't naturally think about for a hormone dysfunction or dysregulation. And then vitamin B6 and zinc have super strong data too. So that's pretty easy. You get a high dose, a multi that has high dose Bs in it can do the trick there. Yep. Calcium, you might need to go a little higher. Magnesium has some studies. Vitamin D has some studies. And then the other one that I love is chaste tree berry, which is it's kind of mixed evidence, but there's good evidence out there for it. So that's another one. Vitex is what we call it. That's the Latin name, and that would be another one that can be great.
I was gonna say, you reminded me of Vitex. Lavella is another one. The lavender extract is another one that I really love, because they have done a lot of studies alongside SSRIs to see that it has been almost as effective as taking an SSRI. The only thing is you have to have taken it for usually about 8 weeks before you start to see that effect. But that's another one to consider, especially if you're somebody that's on the fence of taking an SSRI, or you're trying to get pregnant and you can't be on one. That's one that I've also really loved.
I haven't tried this one for use in practice either, but in 2024, there was actually a meta-analysis of about 400 patients using curcumin for PMS that showed efficacy too, which I thought was so interesting. It reduced severity of dysmenorrhea and cramps and PMS compared to placebo. So they thought that it had like that anti-inflammatory benefit. So with these, I think what's important to know is like when you're getting to the root cause, one thing I love about this conversation about therapeutics is like some are nutrients, some are cortisol modulating botanicals, some of them affect your neurotransmitters. Like you can, if you're listening, and then of course curcumin's anti-inflammatory. So if you're listening, you can probably hear the fact that we're looking at this from like a lot of different mechanisms, and so is the published research that you're seeing research that kind of spans many different aspects of the complex physiology that's going on for women.
Yeah, absolutely. That reminds me, another aspect that we didn't dive that much into is the blood sugar piece. I've seen that be a really
Let's
big
talk more
factor.
about that.
Yeah, is for especially for maybe not PMDD level, but for PMS, of the irritability, the mood swings, the fatigue in particular that you might get right before the week or two before your period. I have seen so many women benefit from working on their blood sugar, and that change has made such a huge difference. I talked to a woman 2 days ago who was like, normally 2 days before my period, I am under the covers in bed. I have to work from home in bed because I just cannot get up. And she's like,
Wow.
I'm at the gym today, 2 days before my period. So she's like, and all we worked on was adding in more fiber and really helping her with getting in a little bit of a walk or a movement right after she ate her meals. So we didn't change anything drastic. Again, it was those simple changes that made such a big difference for her metabolism over time, which then is affecting so many other areas. So I think, even just thinking of PMS as a box of a period issue is not even doing it service, because again, look at the blood sugar regulation piece that we work on that also changes her mood and her fatigue.
Yeah, it's interesting. I mean, it just gets back to that fundamental naturopathic belief that it's like all the symptoms we experience are a reflection of like the environment that's happening inside the body. And I would say inside the cells is really where it starts. So when you look at you might ask, well, why would blood sugar impact PMS? Well, it's because it impacts the way the cells function, which impacts the way they use their hormones or what happens with the metabolism inside of a cell. So unfortunately, it's all connected, and we got to fix the biggest problems first.
Yeah, exactly.
Well, I do want to talk a little bit about birth control pills and oral contraceptives, because these are a really good viable option for women who are experiencing this. And of course, I'd love you to just kind of weigh in on that. First of all, do you agree with me or disagree? And I think the second piece is that oftentimes women don't want to be on oral contraceptives, or maybe they have been and they want to come off to try to treat things naturally. Is that something that you face a lot in practice?
Yes, absolutely. I kind of get the full range of the spectrum of mostly, women who are on it, don't want to be on it. They've heard bad things and they're afraid of it, or it just didn't work really well for them and they want to have a different option. And so, yeah, I kind of get the full gamut. And then I have the women who were like, well, I just can't handle this anymore, and I really just want to be on birth control. I just want to shut it down. I don't want to have to worry about this. So you kind of see the whole range of things when you're doing integrative medicine. And the biggest thing that I like to tell women is there's no right or wrong answer when it comes to healthcare. It's really what is the most beneficial for you and what your goals are and where you're at in life. Sure, maybe for the next year you go on a birth control because where life is right now, you don't have the capacity to add all these little changes in, and your mental health and you getting through your life and being able to do your daily activities is going to take priority over, okay, do a 10-minute walk and meditate every day, right? And so it's really about, what are your goals? Where do you want to be? And are you okay with considering that sometimes we do have to do just a little bit more of I'm going to call it integrative, because I think a lot of people think integrative means fully natural, and that's not always the case.
That's not integrating. You're right. It's like the best tool at the time for the person.
Right.
And I just think about, as you're talking about that, and you're talking about instituting all these changes, if someone's symptoms are so severe and they're experiencing, let's say, depression, for example, the motivation level is so low that to say, like, I want you to get to the gym 3 times a week, like, it's just not going to happen. But if they take an oral contraceptive that manages those symptoms, maybe that gives them the opportunity to like have relief enough that they can start to change their diet or their lifestyle in ways that might get them to be more well later if they ever decide to come off of it. Like, I just think I love the way you're thinking. I love that integrative approach and that shared decision-making approach with patients, because that's ultimately our job, is to like let them know what the tools are so they can make the right decisions for themselves.
Yes.
And I think we have to think about the long game for people.
Yeah. Absolutely. Yeah, exactly. Right. Obviously, being on birth control long term is not the goal. However, like you said, if it helps pull you out of that hole and give you space to work on the other pieces that are going to support you long term, then that's what we want.
So what's one thing that you wish providers understood about cycle-related mood symptoms that might change the way they approach these conversations with their patients?
Yeah, that's a great question. I think just the big pieces that we had already talked about, in how it's not just your cycle or just your estrogen, just your progesterone, right? It's all of these other factors that we want to consider. What is going on with your blood sugar? What is happening with your insulin? What's going on at the earlier phases of your cycle, even when you feel good? How is your estrogen doing? And how are you sleeping? What's your cortisol doing? All of the other factors that go into that foundational health that are also impacting your nervous system, where you are in your life, in your environment, in your stress, in your routines, all of the little things that we maybe don't think about as much. Having that conversation with your patients and just seeing, well, where are they at in life? Where are they at in their daily activities? What can we make a change in? And what is the biggest thing that's impacting them? So I think just instead of looking at it as a disorder, we just look at it from the perspective of, well, what is their life currently looking like?
I love that. I think that's going to leave a lasting impact with our providers that are listening. So thank you.
Yeah.
So I really appreciate you joining us today. Can you just remind our listeners how they might learn more about you, or the best places to connect?
Yeah, anywhere on social media, TikTok, Instagram. I've got newsletters, so wherever you like to be, I'm probably there. So
what is your handle on Instagram and TikTok?
Yeah, it'll be at Dr. Saru Bala, so all one word, no spaces or periods or anything.
Fabulous. And we'll drop that in the show notes for you guys so that you can connect with Dr. Bala if you're in the car driving. Don't do that right now. But I really appreciate you joining us today. It's been an awesome conversation, and I think really helpful for people, whether you're patients or providers. So thanks so much for joining.
Yeah, of course. Thank you for having me.
And all of you that are listening, I hope you enjoyed our podcast today. I thank you very much for joining us. I want to just remind you, if you like these types of hormone conversations, we do release a podcast every Tuesday. So make sure you subscribe to the podcast wherever you're listening from. And you can follow us on socials at Dutch Test. We'll see you next week.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.